I'm Martin Murphy, and I'm happy to welcome you to this edition of Milestones in Oncology, an educational program developed by the Society for Translational Oncology. During this educational session, Dr. Bruce Chabner will host Dr. Paul Goss as they discuss aromatase inhibitors and their role in the treatment of breast cancer. Since 65% of breast cancers express hormone receptors, it is no small wonder that endocrine therapy plays a crucial role in the treatment of this disease. We are fortunate to have Dr. Goss, a world-class expert in this fast-paced field, who is going to give us the status of aromatase inhibitors in breast cancer therapy. Bruce, may I ask you to take it away, please?
Thank you, Marty. It's a pleasure for me to be able to discuss this interesting field with Paul. And I'd like to begin by going back to the early history of the AIs and Paul's entrance into this field. Paul, can you tell us a bit about your training and your initial entry?
Bruce, I was very fortunate. As a young physician, I moved from South Africa to London to the Royal Marsden Hospital, one of the most famous, the original cancer hospital in Europe. And I moved to a hospital that had inherited the tradition of hormone therapy in cancer, dating right back to George Beatson, the renowned Scottish surgeon who performed oophorectomy in 1896 on a small number of premenopausal women with advanced terminal breast cancer, and reported a seminal finding in the Lancet in the 1800s, showing the remission of the disease. And that was when the first appreciation of the link between female hormones and breast cancer's growth and progression was recognized. And that field kind of sat simmering for almost a century. People did similar things for prostate cancer. They did adrenalectomies. And gradually, people began to wonder if there was a way to antagonize estrogen without surgically removing the ovaries. And the drug development of tamoxifen in the north of England yielded that important lead compound. The British became a hotbed of interested researchers in this whole area of hormone-dependent cancer. And I was fortunate as a newly trained doctor to move from South Africa to London. And I was lucky to get a PhD position in the famous Royal Marsden Hospital, Europe's first cancer hospital. And that's where I joined a group, and I became mentored by a group of famous oncologists who went on actually to lead the whole field of endocrine therapy in breast cancer. At the same time, Angela Brodie from the Worcester Institute in Massachusetts married Harry Brodie. He was a chemist. They made a whole slew of analogs, and they recognized that inhibiting estrogen synthesis might be a good way to treat breast cancer. She came to London. We met as a team. It was a famous coffee table discussion around a scientific project, and we conceived of and initiated this field back then.
Paul, can you tell us a bit about this pathway that's inhibited by aromatase inhibitor drugs that's so instrumental in lowering estrogen levels?
All estrogens in both men and women come from androgens, from male hormone precursors. And so there's an enzyme called aromatase that's responsible for that conversion. Interestingly, it's a one-way direction. It can't reverse. So there's this enzyme aromatase that can be blocked, and it prevents the conversion of the pool of androgens going over to estrogens. It does it in men, and it does it in women. The sources of estrogen in premenopausal women are the ovaries, which is the predominant source, and then the peripheral tissues of skin, fat, muscle, and breast tumors. They take androgens and convert. So aromatase is present in the ovary. It's present ubiquitously in the rest of the body, and in men it's present ubiquitously, but not in the testes. It may be helpful to look at a cartoon of the sources of estrogen in women, and you can see illustrated here the ovaries is the predominant source when women are during their reproductive life. After ovarian function ceases, you're looking just at peripheral aromatase. And peripheral aromatase is what we call extragonadal aromatase. It's skin, it's fat, it's muscle, it's mainly fat, and it's fat in the breast. And then in men, it's the same thing. And then finally, there is some exogenous estrogen that we know is in the diet, unwanted estrogens that come off plasticides and from drinking water, etc. And this may actually be a concern. There's also actually aromatase in the clostridia in the large bowel. And these can actually aromatase precursors of androgens in the bowel and feed the body with estrogen. So we've got some endogenous, which is predominantly estrogen source, and a small trickle of exogenous, which may or may not be important clinically.
I think it would be helpful to take a more detailed look at this aromatase pathway.
If we look at this illustration, Bruce, aromatase is the enzyme that converts male hormones to female estrogens in both men and women. It's an enzyme complex, and the aromatase inhibitors block that conversion both in men and women. Importantly, it's a one-way direction conversion, so it can't reverse. So in premenopausal women, aromatase is in the ovaries and in the rest of the body. In postmenopausal women, it's functioning just in the rest of the body because the ovaries have ceased functioning. In men, it's present not in the testis, but in all the other tissues. So male androgens coming from the testis and adrenal go to estrogens through aromatase peripherally. Female androgens in the ovary go to estrogens in the ovary. In the periphery from adrenal and ovarian androgens go to estrogens. So that's where the drugs operate, is on that enzyme.
So what were these initial aromatase inhibitors like? What was their design? And how do they differ from the ones that we now use?
I guess the very first generation inhibitor was fortuitously discovered as a side effect of another drug. That happens in medicine a lot, as you know. So there was a drug called aminoglutathione being developed as an anticonvulsant for pediatric use in children, and it caused adrenal suppression and Addisonian crises as a side effect. But some smart people realized that that could be potentially exploited in breast cancer. And actually the original concept was to suppress adrenal corticosteroid and other hormone synthesis to inhibit breast cancer. But it turned out actually that the drug suppressed aromatase. And then the first custom or designer drug for this was designed by Angela Brody at the University of Maryland in the early 80s, called 4-hydroxyandrostenedione, and we started using it by injection at that time. But it was a weak inhibitor. It wasn't that potent, but it was specific. It didn't inhibit other enzymes. The new inhibitors are more potent, more specific. They lock into the enzyme pocket more clearly. They're better designer drugs, so they're more profound suppression of estrogen. And also, of course, the original drug was an injectable, and then 3 currently used ones are pills, which are the ease of once a day.
Paul, I understand that you took part personally in some of the initial trials of the original aromatase inhibitors. Is that right?
That's absolutely right. Bruce, in 1981 and 82, we were preparing for a clinical trial, which we started in 84, 4-hydroxyandrostenedione given by injection every 2 weeks. The very first patient was treated on a trial that I was leading, and I treated that patient myself. And she was in desperate pain. She had morphine. She had big metastases in her ribs, in her pelvis, everywhere. We gave her once every 2 week injections of 4-hydroxyandrostenedione subcutaneously. 3 months later, during the 3 months, she went completely off morphine, got a smile back on her face. Just 3 months later, I think it says, May 84, you find the rib is resclerosed and reappeared. There's an analogous lesion in the left wing of the pelvis, a great big hole that resclerosed. It was dramatically exciting. We were dancing around the x-ray screen at the Royal Marsden one morning when we saw those pictures.
Had she previously failed tamoxifen?
She had. In fact, most of the patients on that trial had had prior tamoxifen. A few had had other hormone therapies like magestrol acetate, but most had progressed on tamoxifen.
That was quite a dramatic finding. Not only was it active, but it was active in a patient who had progressed on standard therapy, tamoxifen. And this raised real possibilities that the drug might dramatically improve therapy for breast cancer patients.
It did indeed, actually, Bruce, because it did 2 things. It told us that there was a degree of non-cross resistance, so we were hopeful that it might be a superior initial therapy, but it also gave us this window of opportunity that it could be used in patients progressing on tamoxifen. So we had a challenge. That's why when we went to the early stage setting, we did comparative studies of the aromatase inhibitors against tamoxifen as initial therapy, and also studies of aromatase inhibitors after tamoxifen in sequence. So both strategies turned out to be successful.
Well, with this interesting evidence in hand, what was the next step in the development of these drugs?
4-hydroxyandrostenedione, this drug from this trial, went on to global worldwide approval in most countries, not all, not in the United States, and stays on the market today as a useful treatment. But it was quickly recognized several things. Firstly, it wasn't that potent. It wasn't that specific. It was injectable. It caused discomfort at the injection site. So it was a suboptimal drug. But now that we were onto something, designer drugs began to be made in the laboratories, and all types of molecules were made. And interestingly, imidazoles, which came off a ketoconazole antifungal program, proved to be very potent, very specific inhibitors of the enzyme. And that led us to ultimately anastrozole and letrozole, which are two drugs that are used on the market now.
Not steroidal.
Not steroidal.
Yeah.
They're once-a-day pills. They profoundly suppress estrogen. They've got wonderful side effect profile, really, and safety profile, and are highly effective. And then a third compound, which was really the offspring of 4-hydroxyandrostenedione, which was exemestane, was a steroidal molecule that had its inherent androgenicity, but not enough actually to cause virilization in women, as testosterone had before it. And exemestane was the third of these drugs that profoundly suppressed estrogen, but it's a suicide substrate and it inactivates the enzyme completely, and the body needs to resynthesize the enzyme, whereas letrozole and anastrozole are competitive inhibitors that can be swamped out by more precursor. So in enzymology terms, exemestane is a better targeted drug, really. If we look at the structural formulae of the 3 currently used aromatase inhibitors in the clinic, we can see 2 of them are imidazoles, they're non-steroidal drugs, and 1 is a steroid that looks like androstenedione, the precursor of the enzyme. And this is a class difference, which we believe may or may not impart some really important differences in the clinic, both in terms of efficacy as well as side effects. So there are trials looking at comparing the 2 non-steroidals for potency differences, and there's a trial looking at one comparing the steroid to the non-steroid.
So what happened to estrogen levels in patients that were given these drugs?
So it's important to sort of point out that we found quickly that you couldn't use these drugs alone in premenopausal women because the ovarian estrogen production was too strong and too abundant. So we initially began using these in postmenopausal women. The ovary has shut down and you're dealing with just the sub-kitchen of estrogen, the peripheral aromatase.
Yes.
And the interesting thing about this field, very difficult to measure postmenopausal estrogen levels even today. It takes a research laboratory to do it, which is one of the things that's impeded the progress of this field, actually. But the levels are low in postmenopausal women, but interestingly, biologically, they're exquisitely important. They relate to women's health, cognition, bone metabolism, urogenital function, cancer risk, all kinds of things. So manipulating low levels of estrogen in menopausal women turns out to be biologically profoundly important. And one way is to inhibit cancer progression. So the levels are low, but they submerge to below detection by current assays when you use these drugs.
So clinically, do they produce comparable estrogen depletion?
Yes and no. By the original assays that we looked at, they all dropped below the detection limit, so they all looked like, below.
Very potent.
Couldn't measure them. But we now are able to measure differences. So Bruce, we may go on to talk about this in a minute, but there are 2 key questions about the 3 clinically approved aromatase inhibitors. The first one relates to potency, and the second one relates to a class effect of steroid versus non-steroid. So letrozole is a more potent inhibitor than anastrozole. It deepens the estrogen suppression. The question is that clinically relevant, seeing as they both drop it a lot? And the other question is does it cause a difference in side effect profile? So if you have a deeper suppression, is it more effective but has more anti-resorptive effect on bone, for example?
Right.
For the steroid, it's a class difference. Exemestane has androgenic effects, so it drops sex hormone binding globulin levels, for example, which is an androgenic effect. The others don't. And it has some interesting positive effects, as androgens do in menopausal women, not related to conversion to estrogen, because you've blocked that conversion, but in of itself, androgens have a bone protecting effect, a urogenital protecting effect, possibly a psychosexually protective effect, and so on and so forth.
Libido.
So, yeah, libido. So the steroid is a very attractive drug. It also has some direct effect, anti-proliferative effect through its effect on the androgen receptor. So we think exemestane is a dual inhibitor, a dual drug. It blocks. It has a positive effect through the androgen receptor and an anti-estrogen effect through inhibiting aromatase, whereas the others are just pure aromatase inhibitors.
So clinically, that translates into less effect on bone, bone density, I guess, with long-term use.
We think so, but it's interesting. That's an important conversation, because the single most important consequence of dropping estrogen in menopausal women is to accelerate bone resorption. And that's why, hormone replacement therapy improves bone function and prevents fractures.
Sure.
So that's the concern. Now, interestingly, if you close down estrogen, you get similar resorption effects from the 3 inhibitors. But what the steroid does is it improves bone quality. It actually changes the diameter of the cortex and of the bone itself. And it kind of masculinizes, for want of a better way, the strength of the bone and the snapping strength. So we've done some laboratory experiments showing this is quite profound. And so it gives the bone a stronger quality. And there are tests now available to look at this clinically. So we think bone quality is better.
So is it necessary with long-term use of these drugs to use bisphosphonates in most patients on the non-steroidal analogs?
Well, there's an interesting twist to your question, which we need to dissect. Interestingly, women who get breast cancer, by and large, have better bone density. So lifelong exposure to estrogen leads you to in a better bone density situation, and that causes you to get cancer. So in the general population, women with cancer have a better bone density than women without breast cancer. That translates into about 3 or 4 women out of 5 who get newly diagnosed breast cancer in the menopause, having a bone density that's really normal for their age. Only about 1 in 5, maybe 2 in 5 at most, have osteopenia or osteoporosis. So what we've learned is that if you have normal density, you can start on an aromatase inhibitor, and few, if any, women will become osteoporotic if they just take calcium and vitamin D and exercise and good lifestyle. So bisphosphonate prevention with aromatase inhibitors is only necessary in a minority of women who start off osteoporotic.
I see. And with exemestane, is it necessary to take bisphosphonates at all?
We don't know yet. So we're doing some very important pivotal studies in breast cancer patients, and we'll talk in a minute about prevention. And we're looking specifically at going, pre-treatment bone density and on-treatment loss of bone density, use of bisphosphonates, clinical fracture risk.
So, Paul, we've talked about the toxicity of the non-steroidal AI inhibitors, or the AIs, with regard to bone and loss of bone density. But we haven't talked about some of the other important class toxicities of the AIs. Would you tell us something about what problems patients have who take these drugs?
We divide toxicities with this type of drug, Bruce, into quality of life and symptoms as a category. And the other one is serious toxicities that have profound health consequences. So both tamoxifen and the aromatase inhibitors, they cause kind of an aggravation or a mini menopause type symptomatology, where you get aggravation of hot flashes, nighttime wakefulness, sweating, etc. You get urogenital dysfunction. You may get slight subtle cognition and mood and libido effects and so on and so forth. These are things that normally occur with menopause in some women and with these therapies in some women. But by and large, both tamoxifen and the aromatase inhibitors are very well tolerated. Actually, quality of life is very well maintained. In a double-blind study that we did in MA17, there was no discernible difference between placebo and drug. However, so that's, but a small proportion of women do get it, and I think the pharmacogenomic studies may tease that out. In terms of serious toxicity, I think the big important advantage of the aromatase inhibitors is that tamoxifen causes thromboembolism, potentially fatal pulmonary emboli, and other cardiovascular and stroke and other things. Also endometrial cancer. That's its estrogen agonist effect, by the way. The aromatase inhibitors are quite the opposite. They don't have that serious toxicity. In fact, they may reduce endometrial cancer and thromboembolism. But what they do is the single issue that we talked about with bone metabolism. Now, could a long bone fracture in the hip be fatal in an elderly woman? Of course. So a hip fracture is a potential fatal toxicity, but we so clearly understand its pathogenesis. And in fact, the aromatase inhibitors have resulted in breast oncologists looking after the bone health of breast cancer patients so well that there's a net gain for all women with breast cancer, because prior to this, we used to neglect their bone health. Now we're doing it well. If we monitor them, use calcium and vitamin D judiciously, and use supplementation with bisphosphonates appropriately, and follow them and monitor them carefully, it's really not an issue. And the other thing I should just point out in conclusion is that when you stop the aromatase inhibitor, if and when you stop it, estrogen levels come back to normal and you get recovery of bone. So within 12 to 24 months, bone density at the hip and lumbar spine has returned to placebo-controlled levels. So it's really a reversible toxicity.
So, Paul, these are very exciting drugs. Now, maybe you could tell us something about the rollout. They became first interesting for metastatic disease and then for adjuvant therapy, and you were involved in some of the seminal trials there. So let us hear something about the evolution of this as a therapy for people with cancer.
So at the time we began this field, tamoxifen dominated the field. Tamoxifen was given as a prevention of recurrence to early stage breast cancer patients with this ER positive or estrogen receptor positive disease for a period of time. And we learned actually through a series of seminal studies, some of which were done in the United States and Europe, that tamoxifen should be given for around 5 years. Further use of that turned out not to be beneficial and in fact slightly detrimental, which was kind of counterintuitive and illogical. But we began to understand that tamoxifen is both an agonist and an antagonist, and so it's almost a self-defeating drug. And we also think that cancer may learn to read the drug, so you might get an adaptation or a clonal selection to a type of cancer that reads tamoxifen wrongly and flourishes on it.
Mm-hmm.
When we introduced the aromatase inhibitors, we knew that as initial therapy they were superior to tamoxifen in metastatic disease. So the studies looked at head-on-head comparisons of 5 years of aromatase inhibitors to 5 years of tamoxifen. And indeed it turned out that there was a definite and important slight improvement in progression-free survival with aromatase inhibitors over tamoxifen. But I think what helped this field a lot, and I hope turns out to be historically important, is that we designed a trial that I actually wrote in 1997, I think, and we started in about 98, giving women either after 5 years of tamoxifen, if they were disease-free, an additional 5 years of aromatase inhibitors or placebo. The reason we did this, by the way, is because in this subset of breast cancer, we've learnt, and we know now particularly, that there's unfortunately a relentless and chronic recurrence risk, and not just in the breast or regional nodes, but actually metastases is the commonest site, and even in the lowest risk patients, metastases, and it goes on for 15 or 20 years. So 2/3 of all recurrences of breast cancer patients occur between year 5 and 15, not in the first 5 years. So the biggest unmet medical need in 65% of patients is the recurrences that occur after 5 years. So we used this strategy, and indeed the trial, as you know, was a landmark trial. It was extremely effective. And it's now...
It only took about 2 years of follow-up to see the effects.
That's right. The effects were extremely strong. And we went on to learn from the same trial that you could start this therapy at any time in follow-up. And we just have a paper coming out right now. We've presented this, and it still has a profound benefit. So the concept that's been introduced, at least for the 2/3 of women that carry this receptor with breast cancer, is that relapses are relentless and chronic and ongoing, and therapy is going to be needed for a long time. But the good news, and that's the bad news, the good news is we've got a fabulous new tool that can really decimate the chances of this recurrence, and it's really very exciting.
Do we know at this point whether continuous adjuvant therapy with an AI beginning on day 1 after surgery or after chemo, if they have chemo first, is better than waiting 5 years, treating with tamoxifen, and then beginning the AI?
So we are in evolution and understanding the answers to the question, the important question you just asked. The question, to repeat it, is should you start endocrine therapy at day 0 and just give it for 15 years?
The AI therapy.
AI therapy.
Yeah.
Or just endocrine therapy, first of all. And if so, that's question 1. And if so, should you start with just an AI and go all the way, or should you give a little bit of tamoxifen? The so-called single therapy versus switching therapy. The concept behind the switch is that a bit of tamoxifen primes the cancer cell to be exquisitely vulnerable to aromatase inhibition. So the whole concept behind switching is that somehow you set it up for success. It's not shown, it's not conclusive that that's true. So currently, we start with AIs in the highest risk patients, those patients who have node positive disease, those patients who have HER2 positivity, and patients with high-grade and large tumors. For other patients, for medium and low-risk patients, we tend to start with this few years of tamoxifen. But we have learned that a switch somewhere around 2 to 3 years to an aromatase inhibitor is the latest you should wait. So the animal models, by the way, suggest, and they've been highly predictive in this disease of the clinical results, they suggest that treatment with an aromatase inhibitor, and in fact, to be specific, with letrozole, from time 0 indefinitely, is the absolute most successful way to treat the animal. So we have to believe that that could turn out to be the case in humans. And what's happened now is we're rolling out trials where we're giving 5 years of aromatase, and then we're extending it to 10, and we even have a trial that's going from 10 to 15 years of aromatase inhibition.
So we're really looking at the possibility of continuous treatment for the rest of a person's life?
We are.
For high-risk patients particularly.
That's right. So you just put your finger on perhaps an avenue we should just talk about for a minute, which is this for everybody? You know, do all aging women with so many competing causes of death? Because after all, the average age in America is 64. So you're out 10 years, you're 74. You're out 15 years, you're going on 80. And the question is, with all the other causes of death, like cardiovascular disease and so on, and osteoporosis coming into the picture, how wise is it to give so much therapy for so long? And I think therein lies the key question, Bruce. Like in all of medicine and in all of cancer medicine now, is how do we select out the people we need to treat, who will need it, who succeed with it, who don't get side effects with it. And as you know, that's the whole numbers needed to treat game that we're playing in cancer. Personalized medicine, trying to narrow the target population.
So clearly, the longer you treat, the more, the greater the chance of side effects, and so the greater the need for selection of patients. So we need biomarkers. Are biomarkers likely to come out of the current trials?
Very much so, and in many ways. And I think just as a concept in all of cancer medicine, we're looking at characterizing the tumor, the so-called tumor's signature. So there are many, as you know, many biological tools, gene signatures and other signatures on the tumor, which we're trying to say, okay, it's the type of tumor that predicts recurrence. But the other very exciting area is it the host itself? Is it a type of host? So we're looking at host tissues and genomic differences in host tissues. And with the Human Genome Project, we're able to characterize human beings different from one another. Ethnicity is a good surrogate. And no area of oncology is more important than breast cancer, because estrogen metabolism has been shown to be very polymorphic and very ethnically driven. So, for instance, Asian women and African women and Caucasian women have very different estrogen settings for the host. So, and then we have the area of pharmacogenomics. So what polymorphisms and SNPs, etc., determine the metabolism of drugs. So if you look at this triangle, you've got the tumor's characteristics, you've got the host characteristics, and you've got the pharmacogenomic handling of the agents. And if you put together that triangle, you can start to tease out who needs the drug, who's going to benefit, who's going to get toxicity, who do I need to treat. And that parallel strategy with our clinical trials is what we're pursuing hotly.
Paul, I'd like to go back to the issue of what age patient is appropriate for AI therapy. There are a lot of breast cancers that we worry about that occur in women that are age 40 to 50. Is there a role for AI therapy in younger women?
Right, so as you know, slightly fewer younger women have receptor-positive disease. You know, it's sort of linearly related to age. But nevertheless, as you say, there's a 30% or 40% estrogen receptor breast cancer in young women with dangerous breast cancer. As I alluded to earlier, there you have two kitchens of estrogen synthesis, if you like. The main kitchen is the ovaries, and the sub-kitchen is the peripheral tissues. So the strategy is quite straightforward. We have to close down the main kitchen if we want to use this, and we have to close down peripheral aromatase. So ovarian suppression, either surgically or with GnRH inhibitors, will close down ovarian estrogen, and aromatase will close down the peripheral synthesis. So it looks in earlier studies now that this is going to be a very important, successful strategy. So there's several big worldwide trials ongoing probing this. And I predict from all the data that we're going to be into this very soon.
So do you think this is likely to be a better approach than using tamoxifen in a patient who has high circulating levels of estrogen? It would seem that tamoxifen would be at a significant disadvantage.
Yeah, I don't even know that it's high circulating levels.
But as I understand it, in the premenopausal patient, if you give tamoxifen, you elevate estrogen levels, and you're, in a sense, inducing competition for the drug.
That's true, and this is a strategy that I think tamoxifen is being ushered off stage politely as a very famous old actor, both in pre and postmenopausal breast cancer.
Really? Great. So I'd like to go on and discuss then the potential of AIs in prevention. There's been a lot of discussion recently about the need for better prevention strategies. These drugs look reasonably clean, although they have the potential for bone problems and bone fragility and fractures with long-term use. Can you tell us something about the ongoing trials for use of AIs in prevention?
Bruce, prevention is a tough area, as you know, but the exciting thing is we have come up with a pill that can reduce the risk of cancer by 70, 80%, conservatively speaking. It could be higher. Nothing could be more exciting than that. One of the commonest cancers, the commonest cancer in women worldwide, can be reduced in incidence that much. But herein lies the problem, as you know, with prevention. You have the tool that works, but to whom do you give it? You can't take women randomly off the subway train and just start giving them a prevention pill. You have to isolate or select out of the population those at risk who are going to get cancer. And for some cancers, that's easy. You know, familial polyposis coli, there are certain syndromes we know. The BRCA1/2 gene carries that. But for the general population, we've had a tough time finding the women out there who are at risk for cancer on an individual basis.
In the prevention field, we have tamoxifen approved for preventing breast cancer, but rarely used because of the concern about its side effects and the lack of a selection paradigm for choosing patients. We have raloxifene, a similar compound with perhaps bone-sparing effects, which is now going to be considered for approval by the FDA. And we have several very large ongoing trials of AIs as an alternative. Can you tell us a little bit about the AI trials and also about when we can expect to have an answer from them?
The trials the clue that tamoxifen prevented breast cancer came from the original trials of tamoxifen in early stage breast cancer patients, where the contralateral breast cancer incidence was shown to be so dramatically reduced. Likewise, the clues for aromatase inhibitor come from our adjuvant trials. So in the upfront trials, you see this profound and deeper reduction of contralateral breast cancers than with tamoxifen. And importantly, in MA17, the sequence trial, we show that after 5 years of tamoxifen, you give an AI, letrozole, and you get another major reduction in contralateral breast cancer risk. So we now think that there are two roles for aromatase inhibitors, either as an alternative to the tamoxifen idea and raloxifene idea, or possibly in sequence with tamoxifen and raloxifene. So we have a flagship adjuvant breast cancer trial, MA27. I like this trial a lot because it's comparing anastrozole to exemestane. So what it's doing is it's looking at that class effect, non-steroidal to steroidal. There's 7,800 patients enrolled on that trial. It's a US NCI-sponsored trial. And from that trial, we're following long-term toxicities. We're doing sub-studies in bone, quality of life, at all types of endpoints. And we're using that trial as a kind of vanguard of safety, using the same data safety monitoring committees 3 or 4 years ahead of the prevention trials. So you asked about prevention. We have 2 trials in the world. One trial, which I'm leading, and the NCIC from Canada is leading in the North American setting, is the Excel trial, and it looks at exemestane placebo in 4,500 women who are menopausal. It's similar to the prevention trial of tamoxifen that led to approval. Internationally, Jack Kuzik from London is running the international trial of anastrozole against placebo, the so-called IBIS-2 trial. So we have the Excel trial, the IBIS-2 trial, looking at placebo-controlled situation, which is ideal for toxicity evaluation. And ahead of it, you've got the class-on-class comparator. So if you add that together, you've got 6,000 from IBIS-2, 5,000 from ours, that's 11,000, 8,000 from MA27, it's 19,000 menopausal women on study, having peripheral blood collected, tumor biopsy samples collected, bone densities interrogated every which way you can imagine, all types of quality of life, all kinds of toxicities, short-term, mid-term, and long-term.
So you'll get some very good answers from those trials. When do you think the first trial will be actually analyzed and give us an answer about prevention?
It's always hard to answer that question, because what we do is we design these trials to be analyzed when so many cancers have occurred. Sort of ironically, the better the drug is, the longer it takes to show that result, which is good. Good news for the women. So, you know, we think about 3 or 4 years from now we'll have a result. If it's very effective, it could take a little longer. But the important thing is that, you know, we recognize that we don't want to use these drugs for prevention in all comers. So we're trying to narrow the field. And one way of narrowing the field is to collect tissue from women in these trials, and then peripheral blood DNA, plasma, bone density, breast density, all the endpoints that are important, and to interrogate this at the end of the trial and say, okay, can we create a multifactorial paradigm that says this is the profile of the at-risk women. These are the patients who pharmacogenomically got severe toxicity, pharmacogenomically did not, benefited from the drug, etc. So we think that if we were to, my goal is that the 5,000 patient Excel trial, when completed and fully interrogated, would be able to launch a second trial with 500 women, and after that 50 women. In other words, narrowing the field sequentially.
And prevent the same numbers of cancers.
Exactly.
Right.
Yeah.
Now, one group we've sort of neglected here are the men. Do these drugs have effectiveness in men with breast cancer?
That's interesting. And on the slide that I'll show, you can see that male estrogen levels are slightly higher, contrary to what people might expect, than menopausal women. And the original studies of aromatase inhibitors, interestingly, were done in male volunteers. The first in humans was in men. And we measured how much conversion of androgens to estrogens could be blocked. And in fact, it's profoundly effective in men. However, the caveat is that men are a bit like premenopausal women. They don't ever fully go into menopause. That might be good news for men. But men never fully go into menopause. They do have a decline of function, but they don't fully. So they continue to have the pituitary gonadal axis functioning, unlike women who sort of at around 50 or so.
Producing testicular androgen.
Producing testicular androgen. So if you don't block the hypothalamic pituitary gonadal axis, you have feedback hyperstimulation, and you can overdrive the testis, and you can overcome the blockade of aromatase. And so we think that although aromatase inhibitors are effective in metastatic and male breast cancer, we probably, to be optimally effective, should give it in combination with a GnRH inhibitor, the way we do in premenopausal women.
To lower the androgen level
exactly, and then block peripheral aromatase conversion.
That should be a very total blockade.
Right, that's exactly right. So if we look on this slide at the levels of estrogen across different scenarios in both men and women, and here we're talking low levels, picomoles per liter. So something like 40 to 200 picomoles per liter during the ovulatory menstrual cycle in premenopausal women. We're looking at 10 to 40 picomoles per liter in the average postmenopausal woman. A slightly similar but slightly higher average level in men, and that of course goes down with, actually goes up with time in men. And androgen deprivation therapy deprives the enzyme of the precursor, and you see estrogen levels plummet in men. Aromatase inhibitor therapy in menopausal women, look how low the levels go. And finally, importantly to remember, when you stop aromatase inhibitors, the drugs have a short half-life, levels return to normal promptly, and you get recovery of some of the toxicities and symptoms related to this profound estrogen depletion that the inhibitors cause.
This is all very exciting. Do you see any room for new approaches to endocrine therapy beyond AIs at this point?
Yeah, I mean, I think, the term targeted therapy is a new term, but actually the first targeted therapy in oncology was blocking estrogen on its target, the estrogen receptor. So, is there room for classic endocrine improvement? Can we almost obliterate estrogen? Is there further room? Yes, because we think that even residual tiny amounts of estrogen can drive exquisitely sensitive cancer cells. So we want to create the so-called complete estrogen blockade. It's a concept we want to probe, which is the prostate doctors have tried. And so there are trials going on right now where you combine aromatase inhibitor with estrogen receptor down regulators or degraders like Faslodex, fulvestrant. So we're trying to use, there's a trial that's going to report in 08, which will show the effect of anastrozole alone versus anastrozole plus fulvestrant, a very important trial.
In metastatic disease?
In metastatic disease. I ran a trial which I've just had, just about to publish in JCO, a similar concept where we showed equivalence of a complete blockade.
So all of this is based on the idea that we really don't know how sensitive tumors can be, and we don't understand at this point how tumor cells become resistant to the current endocrine therapy. And one of the possibilities, which I've heard you talk about extensively, is that ER-negative tumors, or tumors that escape endocrine therapy, may be exquisitely sensitive to very, very low levels of estrogen.
Right.
So that's an interesting possibility. The other possibility is that they could develop other signaling pathways, so that we really are looking at the possibility clinically of using AIs or other forms of anti-estrogen therapy with drugs that block the PI3 kinase pathway, that block mTOR, that block other signaling pathways that may contribute to resistance. And are you engaged in those kinds of trials?
Absolutely, Bruce, you've put your finger on it. I think we know now, as we probe deeper in the engine of the motor car and we understand this disease better, we're discovering that these cell proliferation pathways and the cell death pathway are cooperating with the endocrine pathway to sometimes drive the cancer cell. So in some patients, we believe right out the gate, you've got a cooperation. It's almost like a school building. You're trying to keep the kids confined in the school, and there's a front door, but here there's back doors, and there's other windows, and there's escape routes. So the cell signaling therapies are coming into concert with the endocrine therapies, either as initial treatment, or the experimental models in the lab are telling us that these pathways, while they may be closed initially, you induce their opening by blocking the estrogen pathway. So it's almost like at the beginning, the front door of the school is open, you shut it closed, but that entices the children to open the windows and get out. And so we're learning this adaptive function. And so we're using the HER2 pathway inhibitors, particularly, Herceptin and lapatinib kind of approaches combined with endocrine therapy. We're now very interested, and we're leading from Mass General Hospital Cancer Center, combination with the insulin growth factor receptor pathway, the IGF-1 receptor pathway. So we're using a monoclonal antibody against that pathway, and the tyrosine kinase inhibitors coming too against that pathway. And then, of course, as you correctly say, down the cell death pathway and down the cell proliferation pathway, you've got mTOR inhibitors, PI3 kinase inhibitors on the cell death pathway, P10 mutant inhibitors. Down the proliferation pathway, you've got RAS-RAF kinase inhibitors, you've got MAP kinase inhibitors, etc.
Yeah. So it's really it's evolving, and we'll have some very exciting trials to look at with regard to endocrine resistance. And I guess the message is we really don't know that any tumor is fully independent of estrogen at this point.
I think that's true. That's a very interesting, the whole idea here is, why do women get breast cancer more than men? And the answer seems to lie in the reproductive years. The fact that, if women never ovulated, they'd probably have the same risk rate of breast cancer as men. And so this is an estrogen-dependent disease from its inception. All the epidemiology speaks to that. All the and animal model laboratory experiments speak to that. And so it does appear that this axis of hormones, and it's all tied into lifestyle, body weight, body mass index, dietary habits, lack of exercise, the pandemic of breast cancer in the Western societies, and the now rising risk of breast cancer in the developing world. Southeast Asia has a booming breast cancer risk rate, related to economic development and the single-child family policy.
Paul, I'd like to go back to the issue of metastatic disease. What were the clues in the initial trials of these drugs in metastatic disease that led to this explosion of interest in adjuvant therapy?
In the beginning, we knew, for instance, that tamoxifen wasn't perfectly effective. Patients progressed on it. There was even a tamoxifen flare. It gave us a clue that in some patients this drug was actually driving the cancer, not inhibiting it. So we used the aromatase inhibitors in sequence with tamoxifen. We took patients who unfortunately had disease progressing on tamoxifen, and we introduced the aromatase inhibitor against other second-line hormone therapies like progesterone acetate or minoglutamide. And we showed this very substantial efficacy in sequence with tamoxifen. Then there were trials up front against tamoxifen, and again the aromatase inhibitors outperformed. None of this came as a surprise, interestingly, because the animal models were telling us that. I guess the counterintuitive question that was hanging in the air was, tamoxifen completely saturates the estrogen receptor in pre- and postmenopausal women. So why would any other anti-estrogen, you're blocking all the off-ramps from the motorway. How does any traffic going to get to the park? What does it matter if you don't synthesize the traffic? If you block all the off-ramps to the motorway, how does it get there? And I guess the answer to that became clearer subsequently. At the time, it was empiricism, like many things in medicine, Bruce. We saw it, we didn't know why. but we saw it. So we said, okay, let's try it in early stage disease. And it worked fabulously well, better. But when one goes, now that we know more about the target, we know that tamoxifen sort of blocks the doorway to the dining room, starves the inhabitants, doesn't bring the kitchen meal. So you do get starvation, but it cheats because it puts its hand in its left pocket and gives back a little bit of food to the table. So it has this slight estrogen agonist tickle to the guest at the table. The aromatase inhibitors just shut the kitchen down. There's no food coming to the dinner party, so the cancer cell says it can't survive. One of the things that we've learned and now understand is that 2/3 roughly of women have hormone receptor positive breast cancer. And we know in this subset of women, the recurrences go on for years and years and years. This Oxford overview meta-analysis slide showing women who've received 5 years of adjuvant tamoxifen or not illustrates the point that tamoxifen indeed improves progression-free survival rates in women. But if you look in both the treatment and non-treatment curves, you see an ongoing monotonous chronic recurrence rate that goes on and on to 15 years. So the survival, disease-free survival and overall survival is poor at 15 years. This slide introduced the concept of the unmet medical need of women who are long-term in follow-up from primary diagnosis. And this introduced the MA17 concept of, can we meet this unmet medical need with aromatase inhibition? And as you know now, the published data that we've published in the past few years illustrate this very profound improvement in progression-free and overall survival in women who are given aromatase inhibitors in extension therapy.
After 5 years. Well, it's been very exciting, Paul. Thank you very much for your participation.
Thank you.
The Society is proud to host this milestone in oncology, and we are especially grateful to Dr. Goss and Dr. Chabner for their enlightening discussion. We are also thankful to our benefactors for their unrestricted grant support and to the peer-reviewed journal, The Oncologist, in whose association these programs are produced. And we're also very thankful to our producers, Michael and Trevor Lawrence. Thank you.